back and to your health, and today we are discussing HIV, and this is ahead of the World AIDS Day, which is on every 1st of December, and this year it's this Friday, which is 1st of December. And as is the norm, we always seek your views on your health. Today we asked you whether you know something about PrEP. This is pre-exposure prophylaxis, and whether you would use this antiretroviral medication if your partner was diagnosed to be positive. Let's listen in to what some of you in Machakos and in Nairobi had to say about this.
Hizi dawa zinaitwa PrEP, nazijua, nazifahamu, na kwa in case nikapata partner wangu ako na HIV, naweza tumia dawa kwa sababu najua zinaweza refusha maisha na zinakuzuia madhara mengine inaweza yenye naandamana na ukimwi.
Kivyangu ningesema ni vizuri kama ni mpenzi wako ako nayo na wewe utaki na yeye hataki kuambukize, ni afadhali aitumie kwa ile muda ambao unahitajika ili aweze kusaidia katika hali ya kulea familia ambayo mko nayo.
Na labda kama mmeoana ni bibi yako, naona kwamba hiyo dawa inaweza kuwa na madhara, sababu ni dawa ambayo utakuwa wakati mnahusika katika ngono mpaka kwanza uitumie. Kwa hivyo kwa njia moja nyingine itakuwa kwa madhara kwa mwili wako. Kwa hivyo njia mbadala ambayo ninaona ingekuwa mzuri kwa kama mtu ameambukizwa na ako na mpenzi wake ni kwamba apate kutumia mipira ya kondomu, ndio at least inasaidia kuliko hili dawa ambalo limegunduliwa.
Yeah, I would do it comfortably because I don't have to infect everyone.
If I'm married to her, then I will. If not, well, you see, that would be a different case. Then it would depend on the level of love that is there.
I'll start with you, Dr. Jarretts, on the comments on those people about their knowledge on PrEP and whether they would use it. You have done a lot of work on HIV and on treatment. What do you have to say about this?
Mercy, first, I am gratified that people know about PrEP and they can be able to talk about it freely and can comfortably. Because it's a new intervention that we introduced just about a year ago. PrEP works. The way it works is that if you are HIV uninfected, that is if you don't have HIV, and you are at risk of getting HIV because of one reason or the other. I think what's coming up is that if you have a partner who is HIV infected, that means you're in a discordant relationship, you are somebody who really needs to consider taking PrEP. And so that will protect you from, you will get exposed to HIV, but you will not get HIV. So it's effective, it works, and it works particularly, most important thing is that you have to take it and take it daily. That is the single most important thing that I think people still continue to know. We know the challenges around people taking medicine when they feel like they're healthy, and we do understand that. But whenever we interact with the people, that we're talking to people about PrEP, we really let them get to know that the benefits of taking PrEP are really huge, that they are investing in their lives, actually, literally. And so we know that there's that challenge. We still also have another challenge where we're still trying to ensure that we have as much access as possible that's available everywhere. Still working on mechanics and details of making sure that when you look to the left, you'll find PrEP. When you look to the right, you'll find PrEP. But I think that said, I think one of the most exciting things about PrEP is that it makes you now make your decisions as an individual that you want to protect yourself. It's good for men, it's good for women. And in particular, we've been talking about women today, knowing that they are particularly at a high risk. We know, for example, about sex workers. We know that they are prone to being abused sexually. They may have clients who are violent. But now with PrEP, they have that autonomy and that power to actually take decisions around their risk of getting HIV. So it's a very empowering thing that you know, yes, you have this pill, you take it at the privacy of your home or of your office, and you are covered and protected. And I think for us, that is really where we find, one of the greatest values we have around PrEP. But of course, as I mentioned, there are challenges. The one thing that we would like to really encourage people is that once they're on PrEP, they should actually be tested regularly, to make sure that they continue being negative, because if somehow, and this is just in the unlikely event, because PrEP is very effective. If you take it regularly, it's unlikely that you'll actually get infected. But in the event that you may get infected, it's good to stop PrEP the moment you actually know that you're infected, because at that point you risk getting resistance to HIV.
Dr. Killins, on what you heard about usage of PrEP and the knowledge of people on PrEP, what do you have to say about that?
So first, I will say that it is really great that we have, one, an additional option for HIV prevention. Two, that people know about it. I think that as we move forward, and as I said, with prevention being a key where we must focus right now. And actually this year's World AIDS Day theme for Kenya, the global theme is Right to Health. For Kenya, we have taken that down and cascaded it towards stepping up for HIV prevention. And Youth na Plan, because again, going to young people. So I think that it's important to be able to have these options. But I also want us to remember that a lot of people who, and especially young people, who do not have access to other health options are also the people who may have least access to the availability or know where to go or have the capability to go and be able to get pre-exposure prophylaxis medication. And so that in itself then creates a challenge where we are going back and saying, what do we need to do better for advocacy? What do we need to do better for other platforms besides just health facilities? So we said young people don't come to health facilities where there can be some sort of access or contact that will then link those who are most at risk to being able to get pre-exposure prophylaxis. And that's one of the things that the NAC is working with, particularly with looking at sports as an issue. We had the Maisha County League, but looking at how we can then fashion that so that we're able to get young people. Because you'll find young people in sport, you won't find them in health. So how do we go and get them from there, especially those that are at highest risk? And then the last item, I think, was one thing that was talked about by one of the gentlemen, condoms. Condoms. We often don't talk about condoms as much as we should. And one of the things we are now saying, we are doing actually, is looking and doing a very quick mapping of trying to find where are the bars and the lodgings in this country and how can we make sure that each and every single one of them has availability of condoms. Because we know there's a lot of sexual practice that happens in those kinds of environments. So it's also taking prevention out there because people would not be coming to look for condoms when they're already in a state where they are having, they're entertaining themselves and would be likely to have exposure and sexual contact. And so we are saying, okay, so can we map out all the lodgings? Can we make sure there's availability and that this is reported on an ongoing basis? So it allows us to take the infrastructure of service delivery that is already at the facilities and take it beyond facilities in the easiest, most appropriate way to the people who need it most.
Okay. Florence, women and girls are using pre-exposure prophylaxis?
I think women and girls are using pre-exposure prophylaxis. I think women and girls started using pre-exposure prophylaxis when it was still being piloted here. And I found that out last year. Nduku knows about the study I'm going to talk about. We set out to ask women and girls. I think from a prevention perspective, even for ICW, we had to really struggle to validate why we needed to talk about it. Because people be like, you're already positive. What do you want to talk about PrEP for? And so we felt it was not important to talk for people. Could we go and ask young people? And actually we did focus on the ages 15 to 24 as well. But in the process, we met a lot of women. We talked to women in Homa Bay, in Siaya, in Kisumu, in Nairobi, and in Mombasa, and girls in school, girls who do sex work, people who identify as injecting drug users. And in the groupings, we found a number of people already on pilot studies for PrEP. And one of the questions that I think I kept finding every time would be asking, do you think this is good? Because the idea was we wanted to have an ICW position around PrEP, and we felt we needed to ask them what women and girls want and then put up that position. And every time we would throw that question, they would ask, be safe from who? And that's why I'm very excited that he said it, that it is one of the, in my view, the only prevention strategy we have now that gives women that power, that empowerment to make a decision that I perceive of myself at risk, and I'm going to go and find this thing to protect myself. It's never been there. I mean, if we have condoms, I still have to go and negotiate that with someone. If you tell me I have to go and do anything else, we have to have a conversation with whoever this person is, and rightfully by their version, who? Because I have my baby daddy and then I have this. That's the environment we live in. That's the environment we find them in. I have the father of my child, but then there's this guy. Then there's the guy I like. Then there's this thing that I found out happens called contract relationships, where you have someone for just 1 year or 6 months and it's written down, and apparently it's a thing in campus. And so, you know, who am I having this conversation with? But if I, in the security of my home, perceive of myself at risk, I can, you know, walk into a health facility or walk into a health worker and sit down and have a conversation, and, you know, if that perception of risk is validated, get a tool from which to protect myself from HIV, from the various other people I interface or interact with. So I think moving on from just having access, which is something that we need to make sure then that is available for all, we need to have conversations around perception of risk. Because, hey, I mean, we go into exams every year and I see sad stories. I don't know why it's always Migori or Homa Bay, but I see those stories of 6 or 10 girls in a class doing exams pregnant. And in their view, they probably did not perceive of themselves at risk for anything. But they're pregnant because someone, somewhere, had sex with them without protection. They are pregnant because we are seeing it. There are many that are probably not pregnant but still continue to be exposed to situations like HIV. So we need to have conversations, especially with young people, around what their perception of risk is. Yeah.
And I'm glad that the theme is, part of the theme is youth na plan, because, well, if they're contributing 51% of new infections, then it's a really important demographic to look at. Dr. Jarretts, I want to ask on the treatment and on there was a CDC report, and I know we've had this discussion about people who have continuously and, let me say, faithfully taken their drugs up to a certain level where their HIV viral load is undetectable, are unlikely to transmit the virus to their partners. What does this mean in the context? Today we've really focused on women and the youth. What does this mean to now this group of people?
Yes, so that's information we've had for many years. Over time, we have built that knowledge. Now, initially, of course, like about 5-10 years ago, we knew that, yes, if you take your medication and take it faithfully, you are likely to transmit HIV. But then we were worried that if now we started people very early on treatment, would it be safe for them? People who've just gotten infected, people who are very healthy, would it be safe for them? And a few years ago, we also learned that it's safe to start somebody on treatment immediately. So the government policy now is that as soon as you're diagnosed with HIV, you begin on treatment immediately or soon thereafter. And that, of course, progressively you will move to a situation within maybe the next 3 to 6 months, at least in less than a year, to a point where your virus, the amount of virus in your body is so little. So this is good news. It is true. Science has shown us that when you are at that level, you are unlikely to transmit. But as we know, nothing is 100% effective. And so we are not saying that if your virus is undetectable, you can actually stop using condoms and you can have sex, unprotected sex. One, because there's still that probability that you can pass infection, and also you can still get reinfected. And so even when we are scaling up treatment and we are encouraged about this, we're still encouraging people to actually use condoms. But the thing that, to me personally, I feel very excited about that prospect that, somebody can be undetectable is for couples who want to have children. In the past, if you're HIV infected, particularly as a woman, it was considered just a matter of fact that you cannot have children. Now that conversation has turned on its head. It's the other way around. And so you have a situation where you have a mother or a woman who is HIV infected, is on treatment, is undetectable, and their partner probably could be HIV negative. And so the tools we are offering now is that the partner, male partner, can take PrEP, okay? The mother is on treatment, and so they can safely have a baby without exposing the negative partner to HIV or to the baby to HIV.
Okay.
To me, I think that is one of the greatest triumphs of this biomedical prevention around treatment and also PrEP.
Okay,
Yeah.
Dr. Nduko Kilonzo, just briefly on that, when the viral load is at an undetectable level, then the chances or there's an unlikelihood of transmitting the virus. Doctors have been accused of always having a bat and an unlikelihood. So your comment on that?
I will agree with the bat that we are accused of, because I think there is never 100% guarantee. But having said that, at least we have made significant advances in science that allow us to confidently be able to say, actually, that we are now able to use one HIV treatment as a prevention tool. So it actually adds to the options that we have, in all the options we have talked about: condoms, pre-exposure prophylaxis. People who are living with HIV and are on treatment and are adherent and have an undetectable viral load actually add on to the tools that we have in this big arena of trying to figure out which is the best way to reduce the numbers of infections. And that's really significant, because it allows us to be able to push that forward. I think my comment around saying what is it that we need to be able to do to make that happen among young people. That is where we have a bigger problem. Young people are not adhering. They are not, those that know they're HIV positive are not taking medication. Those that take medication are not adhering. Issues around stigma, around peer pressure. How do I explain to my friends what I'm taking? Issues around, I don't want the school to know, so I hide my drugs from within the school system. Issues around, I've just found, I'm 20, we are all young, and I've just found this new young guy that I want to go out with. How do I even start explaining that I am HIV positive? And so that contributes to a whole new issue around why we have to reconsider and why we are going back, not just have to, but why we are going back from the point of the government. I know the ministry is doing it. I know communities are doing it. The National AIDS Control Council is going back to say, given where we are and the fact that we have 1 million+ people on treatment, the fact that we have a lot of young people who are not taking on treatment, how do we get everybody to be adherent? And that's where, because I always say, someone once said, HIV starts and ends with behavior. Everything else is in between. Taking medication is behavior. Adherence is behavior. Sexual practice is behavior. And everything else is in between. And so it's always going back to try and say, how do we change behavior for different populations in different ways that reduce their risk or improve their health? It just comes down to those two things.
Okay, thank you very much. So I want to take your final comments, and just before we came back from break, we were discussing, have we moved, or can we safely say we have handled the biomedical aspect of HIV and AIDS, and now we are looking at everything else from a cultural perspective and all the other sectors? So I'll take your brief comments on this, and I'll start with you, Dr. Jarretts.
Yeah, Mercy, I wouldn't say so. We still, again, have a long way to go for biomedical. We've been working on a vaccine for decades. We're still waiting for it. We're confident that it will come.
Okay.
And even beyond that, I think there's still scope to really make even the biomedical tools we have now maybe cheaper and safer and easy to take. I look forward, for example, to, let's say, PrEP, just being an injectable that you only take maybe once every 3 months or so, just like the depot. Even for the ART pill, I think there's still scope to actually have long-acting.
Okay.
And so there's still a lot that we need to explore to really get there.
Florence, just briefly on that.
I think there's a lot that we need to do biomedically. I know we are sitting here going like, can we get a pill that I take once a month? It's really tiring. I know why people don't stay at their end. It's really tiring. And sometimes it interferes with a lot of things. You want to work late. I mean, those pills are not easy to take. They wonk your head. They interfere with you a bit sometimes. And so some people can't take it and get tired and leave it along the way. I agree that there's women who's always looking for a way in which we have prevention that can make us... Yes, just quickly finishing. Prevent HIV and still get pregnant safely. So we haven't gotten there yet. But we also need to work hand in hand to deal with the cultural and the societal issues that affect access and uptake.
Dr. Ali, just very briefly.
So in 2 sentences, I'll just say, Mercy, the first is, where we are, we got where we are with a lot of biomedical. We cannot unstep that pedal. If we do, we'll move backwards. But in and of itself is not sufficient. That is why we are saying we have to go back and look at all these others in order to get to our new infections to less than 20,000 per year, which is where we need to go if we will not have a resurgence of the HIV epidemic by 2025. That is really the bottom line for us as a country. And then may I welcome everyone to World AIDS Day. I can't live without saying that. To World AIDS Day, will be the national, there's 46 county events. The national event is in Nairobi, will be held at the University of Nairobi grounds on 1st of December, starting on Friday, starting 9 o'clock. We welcome everyone to come and celebrate with us. It is about young people and they are taking the lead. Thank you.
Thank you very much. Thank you very much. Thank you for coming this morning. We've been discussing HIV ahead of the World AIDS Day, which is this Friday. And I had Dr. Nduko Kilonzo, who is the CEO of the National AIDS Control Council. I had Florence Anam, who is the Advocacy Manager of the International Community of Women Living with HIV, and Dr. Peter Jarretts, who is the Head of Preventive and Promotive Health from the Ministry of Health. And today we've learned that we have 200 new infections of HIV every day, and this need to reduce. And you and I have a lot to do in terms of behavior so that we can reduce the number of new infections of HIV in the country. Until next Wednesday, when we have another discussion on your health, I wish you a very good day.
Thank you very much, Dr. Mercy Korir, on that. And yes, just a quick reminder, remember the 1st of December, and that